We'll start with the next speakers. John Brownstein is a professor of biomedical informatics at Harvard Medical School and is the Chief Innovation Officer at Boston Children's Hospital. He directs the Computational Epidemiology Lab and the Innovation and Digital Health Accelerator, both at Boston Children's. Dr. Brownstein is also Uber's healthcare advisor, a co-founder of digital health tech companies Epidemico and Circulation. The title of his talk is Optimizing the Patient Journey with Artificial Intelligence. Please join me in welcoming John.
Thank you. Okay, I guess it's a different title, but the same concept. Thanks so much for being here. Tough act to follow with Matt, but I think it does actually tie in quite nicely. One disclaimer, I'm sitting behind the podium because I could have used a digital doctor this weekend, so I'm creating a little bit more of a buffer to you. Also access to water, so apologies in advance for that. So anyways, I'm going to be telling you a little bit about the work that I'm involved in at Boston Children's, and I have this really unique setting in which I run a research group, but I also run the innovation program. So a lot of the work that we do is incredibly applied. It really is focused on how to optimize how patients access care, both within the hospital, but also thinking about how we take the tools and know-how that we have at the hospital and bring that and scale it to the rest of the world. So I'm gonna start with just one example. A number of years ago, I started working on a project with Zach Kohani, who I think is here somewhere. He's one of the organizers. And we thought to look at data out of the Partners Healthcare System. The idea of mining an EMR at the time was basically completely unheard of and in fact frowned upon of why that data would be valuable. We started looking at heart attacks, myocardial infarctions, over a 10-year period and saw this incredible increase. This is a QSUM. And an increase that basically nobody was noticing. Nobody was taking a look at the data. Nobody was really thinking about any changes in patterns that were taking place. Now, it's of course hard to prove causality with these kind of data, but we know that the introduction of Vioxx coincided almost stunningly well with the start of an increase in heart attacks that began. Then with the withdrawal of Vioxx, we saw that peak go away. Now, lots of factors could have influenced why we saw this dramatic change in heart attacks across an entire health system. But the point is that, in fact, nobody was really looking at the data. Nobody had the tools, the methodologies, the wherewithal to start thinking about what is happening with patient populations. But when you think about other industries, we think about companies and we choose to work with companies that use data to help drive our decisions, whether it's news content, shopping, entertainment. All of these companies that have succeeded have used data effectively. And really in healthcare, we've not really seen this take place. And so we're at the advent now with the unlocking of data and some of the incredible work that's going on throughout this conference, but we're not seeing the necessarily transformation that we'd have seen in other industries where I'm not even sure if people recognize these logos anymore. Of course, these companies have been disrupted by others that have really thought about using data and their customer in the digital world. So our thesis is that patients really expect the same service that consumers expect when they interact in the digital world. And it's not for lack of data, and I think Matt really explored this really nicely. Huge amount of data that's out there ready for us to use and leverage. The problem is that these are massively siloed, they're locked away, people hold tight to these data sets, and there's really not a lot of incentive to unlock them, especially when you talk to an electronic medical record company that really their incentive is to lock down a system in an existing setting and not really start to open up the data. Now, Finale actually mentioned the connection to the weather, and so I'll just keep going down that path. Of course, if you think about temperature and forecasts, that is a sort of a no-brainer. We have a suite of apps that are tying into data sets such as NOAA that's been made available for decades through an API that now enables a full ecosystem of tools that allow for forecasting and visualization of the weather. And really, we miss those types of concepts in healthcare. We don't have the underlying data sets that are made available. We don't have an API to that information. Of course, no underlying suite of apps that allow us to tie into these settings. So really, our focus has been thinking about how to get all of these things moving at the same time. And to sort of go down this path of weather and landscape, of course, when you think about geographic information systems, this field has exploded with the idea that these data sets have been made available, they're organized by location into one common set and framework that people can then do analyses. And so there's no reason why in health information commons can't be organized by the patient side. So huge amount of data, once again, said very nicely by the previous two talks about where the data might come from and how we might tie this together. And in fact, there's ongoing work happening led by Zach Kohani in the Department of Biomedical Informatics in an effort called BD2K to really try to create a patient-centered information commons that starts to tie all these data sets together. In Boston Children's, so I'm very fortunate to have access to an amazing amount of resources and organizations that we work with to sort of begin this process of tapping into these data sets. We have an incredible, vast amount of data on the complex and rare patients. We have incredible clinical expertise, and we actually have some amazing work in informatics. So our goal has been to think about how do we start to extract all that know-how, that data, and begin to work with partners, then to begin to optimize that patient journey. It's not going to necessarily happen, and there was a question about how to bring these things to scale. It's not necessarily going to happen just by pure research. It's going to happen through launching of new ventures, new partnerships with enterprises, large and startups. Within our own team, we have a dedicated amount of resources. So this is unique for a healthcare system where we actually have data scientists, engineers, full stack engineers that are building tools, not only for piloting, which has always been historically what innovation has been all about, but actually thinking about bringing things to implementation, bring them within our own healthcare system, but building them with standards that allow us to build tools that exist in other settings. And at the same time, not afraid to work with outside partners. I think part of the issue in many hospital systems is that they start to look very inside for solutions, and they don't realize that there is huge amounts of dollars being poured out to the outside world in new domains. So we're obviously thinking about, when we think about new tools, we're not trying to reinvent the wheel. We think about all the efforts that are going on, especially in this amazing Boston ecosystem, that are really driving innovation in data science and healthcare. So our goal has really been thinking about the patient journey. What are the areas where digital and data can optimize how a patient receives their care? And we think about this in a very broad setting. We're not thinking about this just about how that patient receives their care once they're in Boston Children's, but throughout the entire course of their journey. How does a patient find information online? How do they get treatment insights that are based off the web? Once they're in a system, how do they start to get their treatment optimized? And then once they've left, how do we begin to remain connected to a patient through remote monitoring tools and care coordination tools that enable us to have a much deeper view of a patient, not one that's one-off on a yearly basis, but one that's much more continuous. So just to talk a little bit about within the hospital, BCH, Children's Hospital, really represents a place where people come for especially a huge number of second opinions, for expert consultations around rare and complex diseases. And we have an incredible insight to provide guidance to patients. At the same time, we're not necessarily leveraging the data that we collect across the house in ways to really optimize that care. So our goal has been to think about where are the places across the house where we can do a much better job. So one area, of course, and an example in AI that comes up quite a bit is in radiology. You can imagine that we have an incredible amount of historical data when it comes to imagery. We're taking 30 to 50,000 images per day. That incredible repository has really not been utilized in a way to actually make better decisions going forward. So we've now actually started to optimize that data, bringing that into tool sets that allow us to make more automated approaches to distinguishing normal versus not normal. We have incredibly tagged data sets across a range of rare conditions. We're actually partnering with GE in this space, and the early results are really looking incredibly promising to actually build just basic tools that can distinguish something that looks like a normal image versus something that's irregular and that requires deeper analysis. So there's the imagery area, but then there's also the time series perspective. Vast amounts of data come through in, for instance, high-intensity environments like the ICU. Huge amount of data is coming in real time to monitor patients, and the idea of using that historical data to really understand insights is not something that's traditionally done in this field, but it makes so much sense. And this is actually work that's led by Maurizio Santillana, who's really been thinking about how to take these data and make better decisions. So the idea is that we get all this ventilator data, we get airflow information, we get oxygen information. Why not start to take that continuous data to make estimates of, for instance, ventilator-associated conditions? We know that the earlier the detection of a condition on a ventilator and earlier treatment can obviously mean saving a patient's life. At the same time, we can also think about optimizing capacity when we understand how patients are doing on ventilators. So this is just one example about ventilator-associated conditions, where if we start taking data about oxygen airflow and other estimates coming off the ventilator, we can actually identify a condition days ahead of when, say, a physician with their naked eye was looking at this data. So you can imagine days in an ICU can mean a huge amount for a patient. The same goes for length of stay. There's a lot of ways in which we might predict length of stay. We get real-time data, but then we also have demographic information about patients, their age, their various conditions, associated conditions. Combining all that know-how together creates a much more optimized view of how long a patient is likely to stay in the ICU. So for a particular patient, understanding that really can impact course of treatment. But even from a cost perspective, you can imagine that understanding length of stay can really let us understand capacity in a hospital setting. The ICU represents our highest cost environment, so being able to take that know-how to plan for capacity means that we can start to, of course, reduce overall costs of the healthcare system. Lots of other opportunities exist, and actually this one I think I directly credit Matt with, because he really started down this path of thinking about N of 1 treatments and conditions. So his story is one that we're trying to codify into a process for the hospital. We've just launched a precision medicine clinical service with the idea that very similar to his case, with the concept that we can do deep phenotyping on patients, but also bring in patients from around the world that potentially are on this diagnostic odyssey, which maybe they've had a genomic interpretation, maybe not, so they can come to the clinical service, get a reinterpretation, then do deep biological understanding of that particular mutation. The goal, of course, is this idea that we could arrive at new treatments for patients that are sort of the N of 1 or N of few that ultimately can lead to that cycle. So reducing that diagnostic odyssey all the way down to treatment is actually not just a scientific paper now, but actually a reality that's being implemented today. From a capacity standpoint, huge numbers of opportunities, and these are probably less sexy areas of AI, but I would predict that these are going to be the more common ones that you're going to see come up in the next year. One example is around a triage. So someone shows up to the emergency department. We have to make a decision. Is this person going to get admitted or are they not? Usually that can take hours before that decision is made. The problem is once a decision of being admitted is made, then they need to find a bed for that patient. So the critical area is, well, why not start to understand how likely that person is going to be admitted well before that decision is made normally? And so we can take presenting symptoms and demographic data and actually make predictions of an admitting of a particular patient. That can save huge amounts of dollars and also optimize the patient experience. We actually now have implemented this concept. This was a methodology developed by Ben Rice and Andy Fine at Boston Children's. But more importantly, we've now taken this machine learning tool and brought it into a visualization that's now used by a dashboard by nursing to actually look at the probability of a patient needing a bed. And even further now, we've taken these tools about predictive analytics and likelihood of patients not necessarily being admitted, but the length of time that they're going to stay in a hospital, and now we're bringing this into a hospital-wide capacity dashboard. So this is not just theoretical concepts of likelihoods of patient stay. These are actually directly applied into a healthcare setting. Okay, so I'm going to pivot a little bit here, just to get into a little bit more of my own personal background. Of course, there's many different opportunities for innovation and use of large data sets and machine learning in healthcare. But when you start looking at the determinants of care, of course, huge opportunities in genetics and care that people receive. But if you look at context and outside of the healthcare system, that represents such a bigger part of the drivers of disease. So healthcare behaviors that individuals have, their local context, their geography, many of these are actually what are driving the major health outcomes in our country as well as costs. So a lot of my work has been focused on thinking about, well, what are the data sets outside of traditional healthcare that can allow us to understand health behaviors, health outcomes, and allow us to intervene well outside of existing healthcare systems. So we term this concept of the digital phenotype. It's this idea that all the data you generate through your interaction with technology, whether it's social media or your devices, all those digital breadcrumbs can actually begin to bring some really unique insights about a patient. So our goal has been how to take all that information, organize it about patients, and begin to get insights. I'll give you some examples throughout. One example, of course, foodborne illness and infectious disease that I'll give you some examples on. Chronic disease, the idea that there's a lot of disclosure and discussions about people's chronic disease online that never comes through their interactions with the physician. Drug safety, new signals that are actually obtained through just people's disclosures of their experience on medications. Drug diversion and abuse, and I'll mention this in a moment. We get all sorts of insight on how drugs are taken off label and abused well outside of any clinical data that you would ever find. And then, of course, patient experience, the idea that we can actually understand how patients are receiving care, settings that are much cheaper and oftentimes more reliable than, for instance, surveys that patients receive. So the way we do this, and we've been doing this now for over a decade, is this idea of ingesting large data sets from as many sources that we can identify or scrape on the web, and begin to develop tools to organize that information through keywords, through machine learning, to essentially come up with ways to identify important public health trends through these data. And I'll give you some examples about how we do this. Not only providing new early signals about public health events and populations, but also getting access to data at a much more global scale. You can imagine that the data that we have across clinical settings is very geographically refined. We're not going to get data across a country, let alone a globe, about healthcare or data about outcomes, especially when it comes to infectious disease. So we've been thinking about the data that exists outside of those realms. Our first effort in this space was a tool called HealthMap. It's a global tracking system that basically ties in as many data sources as we can get access to. So across hundreds of different sites and hundreds of thousands of websites across 15 languages, the idea is that we can start to scrape the web looking for insights about disease in populations. This was very focused initially on infectious disease. The idea is that all the data that's being produced by these sites can provide us early insights about outbreaks and other epidemics in populations. So the idea, very simply, is scraping all this text that exists on the web, and it's very different than, say, free text that you would find in clinical notes, but the concept is still very similar. We would build taxonomies based on disease and location, beginning to organize that content with the idea that all this disclosure about disease in populations and organize can start to provide us a structured database that we can then use for public health purposes. We then use machine learning tools to that once data is characterized to basically weed out the noise. You can imagine huge amounts of noise coming through a system where you're just scraping the open web looking for reports of undiagnosed disease and mysterious outbreaks. And so organizing that information, taking all the relevant data pieces and generating really a huge amount of data about disease across the globe in ways that, for instance, organizations like the WHO had not seen before. WHO is an active collaborator as well as CDC that are now using these tools as a way to understand disease events and respond across the globe. So this is basically our visualization tool. It provides data not only to government officials, but also back to consumers, which is really critical. So lots of examples of how these kind of data sets have worked in the past. I don't know how many people still remember swine flu. I'm feeling a little bit like swine flu right now, but something, H3N2, I guess. Digital disease detection, this concept, was sort of started really with this idea that with the emergence of H1N1 swine flu, where we had a mysterious illness in Veracruz, Mexico, where there were actually a local newspaper talking about a mysterious illness. This was not being reported by CDC, not reported by WHO or Mexican authorities, but the first signs came out of this sort of local crowdsourced information that then we could take and actually alert health officials about. More importantly, we could start to organize huge amounts of content to actually trace a virus as it emerged from a particular location around in Mexico as it moved around the globe. Fast forward now to more present day, we're dealing with a slightly different set of data sets. H1N1, limited amount of social media, slightly better than SARS, where there was almost no data coming out of China. Now with new flu strains, for instance, H7N9 out of China, totally different setting, where over 10 years ago, we couldn't get any insights about what's happening. Now we have access to social media sites like WeChat and Weibo, where we're actually mining detailed data about cases that are being presented on these sites. all sorts of other data sets that we can tap into. Of course, maybe many people here remember the concept of Google Flu Trends. It was somewhat a failure in terms of technology, but it was very helpful in terms of the sort of vision it put forward. This idea that what people search for online is a tool that can be harnessed and get new insights. And people have published many, many papers about the value of search query data as a tool for early insights about infectious disease, health behaviors, chronic disease. And so we've been taking this topic on to really think about all the data sets that can be valuable, not only for flu epidemics, but many other types of epidemics. And this is, once again, worked very closely with Maurizio Centinana, where we've been thinking about other data sets. So data from Wikipedia, how many times someone goes to a Wikipedia page about flu. That turns out to be a valuable set of data as well. And so we started to organize all this content across many sites, whether it's Twitter, whether it's data from electronic medical records, to create one composite score of flu that now is a much more valid score than, for instance, any particular data set alone. And in fact, right now the data is showing that we're at really close to peak time in an influenza season. This is methodology developed by Maurizio, showing a methodology that uses not just data on the current present, but also previous weeks of data to make forward predictions. And so it's not necessarily like these are methods that have completely not been around, but they've just never been applied to these types of settings. How many people use OpenTable? I don't know, I'm sure some people use OpenTable. Do you know that OpenTable data can be actually used to track flu epidemics as well? So the numbers of cancellations of OpenTable reservations. I'm gonna cancel my reservation tonight, but that data in itself is highly valuable. So it's really amazing when you start to sort of deepen into some of these data sets. They actually all have some level of public health value. And it's great to see some of the companies, Silicon Valley companies, starting to open up their data, making them more available for these purposes. If you look at more global public health issues, the emergence of Ebola, once again, an example where data mining and access to a variety of different data streams could provide incredible insights into what was taking place, not only for situational awareness, but then also from risk analysis. So you could start to tie the data from what we knew, the locations of cases, to transportation data to look at where we might see future translocation of cases. And increasingly using that data to then make future predictions of Ebola cases. So tying the data that we have about that outbreak plus previous outbreaks and landscape information, we can start to make risk assessments of where we might see future introductions of the disease. Of course, can't talk about infectious disease without mentioning Zika, another example where the mining of disparate data streams from across many different sources provided a view that you couldn't get through just going to a local public health website, tying in news, social media, data from government agencies into one resource provided this actually a way to understand what was happening, but then also tying that data back again to, for instance, mosquito distribution data, where we can actually have very detailed risk maps of where we might expect cases. Yelp, I should have mentioned Yelp as well. So I'm not sure if people know this, but 10% of all Yelp reviews are food poisoning related. That's surprising, probably to some of you. I'm not sure how many people write Yelp reviews here. But incredibly, if you start to extract the data from those Yelp reviews, you start to see people mentioning specific ingredients that cause their disease. And when we spoke to the CDC initially about this, they would be like, there's no way that a consumer knows what caused their illness. When we started drilling that into it, the ingredients that consumers implicated versus what's implicated by CDC are stunningly matched. We almost didn't believe the data. And so from our perspective, the consumer, the patient, is much smarter than we give them credit for, and we start to think about other opportunities to engage patients. So we built a whole system, and this was done with a city of Chicago and then many other cities, where we actually built a foodborne illness surveillance system based off of Twitter and other sites. But the idea is very simple. People tweet about their diarrhea in huge numbers. You'd be surprised. It's really unbelievable. But if they do that, why doesn't public health agencies actually try to engage back? Sorry, you're feeling sick. Why don't you fill out this form and we can do an investigation? And so now we're working with various cities and municipalities to actually direct resources so that investigations can happen based off of what the individuals are saying. And we always say putting the public back in public health. The idea that they can help, that an engagement with the public can actually help drive public health decision making. And this is work with Google, where post-hurricane we've started looking at Google searches where we might see, for instance, gastrointestinal disease. This is just work that's ongoing, but once again, many different data sets that we can tie into. On the non-infectious disease side, lots of other examples as well. So for instance, in medication use. So we know that there's huge amounts of lack of information about how people experience products. And this is very important, of course, and we've heard in the previous talk, the importance of understanding adverse events related to products. But if you understand the amount of data that goes to the FDA, it's a small sliver of what actually gets, of what is actually happening in the population. And so our perspective on this was, if people don't realize they can report to the FDA, why don't we just go to where people are talking about these issues with medications and amplify their voices? So we built a tool called MedWatcher, which is an FDA-supported tool, which was essentially mining the open web, looking for people's disclosures about their experiences on medication. So we we built a tool that essentially takes what people say online about their medication and translates that into the elements that are needed for an adverse event report: a time, a reporter, a drug, an event. And from that, we can actually start to organize all that content. You can imagine trying to do this at scale is really complicated. Things that people think about when they mine EMRs, but also a lot different as well. Typos, spelling variations, invented words, hashtags. You're not going to see hashtags in an electronic medical record. You're not going to see eating like a mouse written by a physician. So lots of different ways in which people talk about their conditions related to their products, but not in the ways that you would expect. So it takes a huge amount of curation and development to get to a place where we can start to organize this content and actually take the ways in which people talk about illness and code them to more traditional taxonomies. And then from there, start to build machine learning tools that once we've coded a drug and event, what is the likelihood that the FDA is going to care about it? And thinking about training particular, for instance, tweets or Facebook posts or forum posts based on what we know are combinations of words that lead to something that is actually a valuable data point. And so we building tools to essentially estimate composite scores on a particular tweet that lets us know whether this is worth sort of investigating further. And what's amazing is the data itself is incredibly valuable for understanding what's happening in the population, but very different than, say, what's reported to the FDA. Generally, the types of things that get reported to the FDA are much more severe. So you're not going to have someone experiencing a heart attack and on the way to the hospital tweeting out that they're experiencing a heart attack from the drug that they're taking. But at the same time, people are mentioning the rashes, the sort of very minor issues that they're experiencing with their medications that never make it to the FDA. And you can imagine from an adherence perspective, not having access to that data can really change our understanding of a disease. Okay, figure I'll get through all the social media sites by the end of this, except for I have no Tinder studies, so just, I know you were excited, but it's not happening today. Hopefully someday. Okay, so Instagram, I assume, how many people here on Instagram? Okay, that's okay. What did I expect? It's sort of segregated by age a bit. So the idea here, of course, use Instagram talk about how awesome your life is, but people use Instagram for other reasons as well. Like you cannot imagine the amount of drug abuse and diversion that's being disclosed on open sites, talking about people that are abusing drugs, but also diverting those medications and selling them, providing all sorts of different interesting ways that they want to expose how they're abusing products. So our thought to ourselves, well, if people are that open about talking about their abuse of opioids, why not build a site where people can just talk about their experience in buying opioids? So we launched a site, this was actually a number of years ago now, although the topic is, of course, much bigger right now, with this idea of will people talk about the price they paid on the street for the drugs that they bought? So this is StreetRX. And it's the idea, it's very simple. People come to the site and they report the price they paid for any drug, and there's PIL IDs so they can know exactly what they bought. And then other people come to the site and say you got a good or a bad deal. And so we are actually able to get a very specific view on the black market of every product across the country, and in fact across the world. So we published some of this data, and before you get horrified by why you would make a website like this, I'll get to the punchline soon. But before that, the idea is that the potency of a product is directly correlated to its value. So black market, incredibly smart in understanding how well a product and how much it's going to go for. So we were able to show that it does well, and in fact, probably the only scientific study ever to use data from Silk Road. I don't know if people remember Silk Road, shut down, but in fact, the only paper probably to have used that data before it shut down. But we were able to show that the data coming from our website worked just as well as, say, data from law enforcement. The only difference is our data shows that the drugs are cheaper, mostly because law enforcement overpays because they're trying to do a drug bust, so they're going to overpay for the product. So we have probably a truer view of the product pricing. Okay, so why do we do this? Very limited real-world data on how these drugs are being abused, whether they're being abused, holding pharmaceutical companies accountable for what is actually going on in the real world. Very limited amount of data. But when you have, for instance, new formulations of a product like OxyContin that you can't crush and get the active ingredient, you can start to see the real-world impact of that. So as soon as a new formulation of OxyContin was released into the market, the price dropped dramatically because people didn't want it anymore because they couldn't get high off of it. So you can start to use this data, and this is data we actively work on with government agencies as well as poison control centers to really understand what's happening out there, what are the new products people are abusing, if a new product hits the market, is it being diverted, and what's happening. Okay, so a lot of our work is now starting to focus more on understanding the consumer and the patient, and how do we start to do a better job of engaging patients and consumers around healthcare. So there's been a lot of work, and I won't spend a huge amount of time on this, but we think about, as I mentioned, putting the public back in public health. How do we not make individuals a data feed for a research analysis, but how do we make them much more active participants and valuable part of the ecosystem as well as users of the data that we're capturing? So we first started this path and back down to flu, of course, a project called Flu Near You. And this idea that we're just asking people how they're feeling on a weekly basis and whether people actually want to be part of a system that's crowdsourcing influenza. And we just ask people to spend a few seconds every week telling us how they feel. And amazingly enough, lots of people are willing to do this. If you engage people and make them part of helping the fabric of flu surveillance across the country, you actually can engage people. And if you provide data back to people, you can get tens of thousands of people actively part of a crowdsourcing system. And what's great about that is it's way cheaper to run a crowdsourcing system than a government system that's tying in to physician offices or other types of data sources that requires millions of dollars to run every year. And on top of that, you get much finer resolution data on demographics, on vaccination status, on geography. So many of the data elements we'd capture from more traditional systems are improved by doing this cheaper sort of engagement, on top of the fact that you can start to tell people about influenza and immunizations in ways that you couldn't with these other systems. It's still hard to get people to engage, and so we're not looking for a 100,000 person system, we're looking for millions of people. So we're actively looking at other tools. So this is Thermia. This is actually a fever support system designed for parents and adults to understand what it means to have a fever. I have young kids. I was like, my child is 102.3. What does that mean? Nowhere I can look to understand what that means, but in fact, we have all the protocols at Boston Children's to take that and give some recommendation back to patients. So we built this tool that gives recommendations back to patients about the fevers that their child or their family members are experiencing. But more importantly, on the back end, now we're capturing incredible data about symptoms, about fever, about vaccination status, and once again, that can feed into surveillance. We can start to think about taking these decision support tools that we're building for consumers and pushing them through all sorts of different content distribution channels. One area is in devices. There are many wearables and tools that have sort of evolved to, for instance, do temperature tracking, whether it's one-off temperature sensing or more continuous temperature monitoring. But the idea is that we can start building in our decision support tools right into those devices and provide parents guidelines right from their app. So the idea is they take a temperature of a Bluetooth connected thermometer right into the app, and now we can actually provide decision support right with Boston Children's guidelines right to the individual where they live, as opposed to having them come into the emergency department. And then, of course, beyond just devices and apps, huge numbers of new tools and next generation user interfaces that are evolving. We're working with a number of companies and efforts around symptom tracking. You can imagine, you go into WebMD, you put in a symptom. I mean, pretty much everything ends up as cancer anyways. But if you actually thought about it, there's an incredible amount of literature out there that if you started to harness, you can start to really direct people to the right outcomes and help them triage themselves, not have them end up in emergency department for an unnecessary reason. This is a company, Bowie, that's actually out of Harvard. So Harvard medical students that started it. And the idea was very simple. They wanted to take all the knowledge out there to help build a way to inform patients of what they need to do next before ever arriving in the emergency department. And the data is incredible. It's really showing that there is a huge amount of validity to the outcomes that the decisions that it's making on behalf of the patients compared to what clinicians are doing. And we're already in sort of 92% triage accuracy. We're only going to get better from there. And of course, there's all sorts of new channels to engage. This might, if only half the people on Instagram, I'm going to be a much smaller number of people on some of these tools, but they're going to be much more, sort of widespread as time goes on. We've been very interested in the opportunities around voice in healthcare. So the idea that we can actually tap into a voice-based virtual assistant to provide us with knowledge. So the idea that we could take our fever tool, but a whole set of other tools and provide guidance back to parents about what to do with their kids. And so we actually built the first healthcare skill for the Amazon Alexa device that is now providing insights to patients. Okay, I'm starting to run out of time. So I'll give the last part of this talk, which is really around logistics. So it's all well and good to provide sort of guidance to patients, but the sort of what next perspective is really clear as well. So we are thinking a lot about how to deliver interventions. So one area is around vaccines. Of course, we talked a lot about flu, many other vaccines that are out there. We created a tool with Google, actually, it was called Vaccine Finder, where we tie in all the data from pharmacies and organizations across the country that provide vaccines into one tool that allows people to decide where to get what shot and how much it's going to cost, and really sort of drive decisions towards getting critical vaccines. The challenge is, even though I can't walk a block without getting a sign about a free flu shot at a CVS, people are just not doing it. So we thought to ourselves, well, why not reach out to a company? And I know Uber's changed its, I guess it's the people's feelings towards Uber has changed over the last few years, but the reality is that whether it's Uber or Lyft, a logistics network that exists can be deployed to healthcare makes so much sense. And so we reached out to Uber with this idea, why not put nurses in Uber vehicles and start to deliver vaccines? And so we built Uber Health, and we've done this now for several years, where we actually add a button onto the Uber app where it allows people to select health and then get vaccines delivered to their door. And this is, once again, just an example of what you can start doing with existing technologies that are out there. We were able to deliver thousands of vaccines in 40 different cities, and in fact access people that would generally not get a flu shot. So people that are not the ones that are necessarily getting a flu shot, don't have it access at work, those are the people that we could get access to. And of course, huge populations we weren't accessing, but if you think about the people we did, many of those had never gotten a flu shot in their lives, almost half had not gotten one the year before. On-demand becomes increasingly important in people's decisions around healthcare. So as we start to move forward, healthcare logistics is a bigger and bigger piece of what we're thinking about when it comes to the delivery of care. And in fact, we're not alone. Lots of different companies are emerging now that are thinking about prescription delivery, home care, all sorts of different ways to take the healthcare system out to the individual because people want that. One example is we launched a product out of Boston Children's called Circulation, which is essentially this idea of it's impossible to get patients to come to their appointments because many of them face barriers when it comes to access to transportation. So providing a $10 Uber ride or a Lyft ride makes so much more sense than a missed appointment, which can cost hundreds of dollars. And so by providing new transportation options that are not sort of taxi vouchers, which are really difficult to track and misused, we can also change the ways in which people access their healthcare. Now, that's getting healthcare to the individual, which is still, healthcare bringing them into the system. That's old school. The idea really is how do we start to bring healthcare out to individuals, whether it's product delivery, whether it's bringing caregivers, and then also in public health crises. So the idea that you don't have to have people moving around the population looking for vaccines, we can actually get vaccines delivered to individuals. So all sorts of new logistics opportunities that are now opening up. Lots to imagine in the space. there's the idea of the mobile clinic that comes to you very clearly. There's the idea that you can bring a defibrillator or some kind of critical medical device. This is a company, Piaggio, that's developing autonomous vehicles that can deliver whatever you need in a particular disaster. And then, of course, the idea that you can start to do delivery. Now, of course, probably a gratuitous drone shot to end the talk, that's fine, I can take it. But the idea is very clearly that there's huge opportunities and new ways in logistics to get care, especially this, of course, this company Zipline that's doing this to deliver medications in remote locations. So I'll just end there. I know I'll probably run out of time. So lots of challenges, of course, and so I don't want to end on a downer, but lots of things to, of course, consider as this field emerges. The methodology is a big part of it, and this is really what the group is focused here on. But of course, accessing this information, integrating these sources, and a variety of other topics that we need to consider. So leave it there. Thank you so much.
We're taking one quick question. This one there.
I'm curious what you do about data privacy. I'm surprised at the number of names you had on your Twitter.
Right, so that's public data. So based on Twitter policy, that data, as long as it's represented properly, it's fine. These are not people that have created private Twitter handles. They've made their data publicly available, and so we're following the same privacy. Of course, it's very different for other sources of data that you wouldn't have seen. So we're only using any public accounts that are out there. Huge amount of data that I talked about is aggregated, de-identified. We've actually published a lot on de-identification methods around keeping data, this kind of data private. But yeah, so the Twitter data in itself is, and you'll see Twitter public handles across news organizations. So we're following sort of convention there. Yeah. Okay.
Thank you. Thank you.